The following podcast is part of a certified educational activity titled Illuminating a Better Path Forward for HR-positive, HER2-negative metastatic breast cancer, Bridging the Science and Art of Medicine in Clinical Decision-Making. Access the entire activity and complete the post-test at peerview.com/VPA860. Downloadable slides and practice aids are also available.
It's a pleasure to join with you today with this CME event from PeerView, talking about illuminating a better path forward for hormone receptor-positive, HER2-negative metastatic breast cancer, bridging the science and art of medicine in clinical decision-making. I'm Komal Jhaveri. I'm a breast medical oncologist from Memorial Sloan Kettering Cancer Center. I serve as a section head for our endocrine therapy research program there, and I'm the clinical director for our developmental therapeutics unit. And it's absolutely a pleasure and an honor to have a very dear friend and colleague, Professor Giuseppe Corigliano, who's a professor of medical oncology at the University of Milano and director for the Division of Early Drug Development for Innovative Therapies. So welcome today. And we have three goals for today's discussion. First, we'll talk about how can we augment our knowledge specifically about CDK4/6 inhibitors and oral SERDs for hormone receptor-positive, HER2-negative metastatic breast cancer. We hope that today's discussion will equip you with strategies for developing individualized treatment plans for your patients, and ultimately also provide some guidance on monitoring and management of adverse events and improving the adherence and persistence for our patients in clinic with this subtype of breast cancer. Breastcancer.org is our patient advocacy partner for this activity, and their mission really is to help people make sense of the complex medical and personal information about breast health and breast cancer so they can make best decisions for their lives. They also help the global community of patients and care partners, and they offer trusted educational content, community conversations, and other resources. So please access and share the supplemental downloadable resources, especially for your patients, that you see in clinic. So we have divided today's discussion in two parts. Professor Corigliano will be discussing part one, which will focus on individualizing the selection of first-line therapy in hormone receptor-positive, HER2-negative metastatic breast cancer, and walk you through the latest evidence and practicalities with the case as well. Dr. Corigliano.
So we start with a clinical case. So this is a 62-year-old postmenopausal woman. So she was diagnosed with a 3-centimeter mass, and she underwent lumpectomy, adjuvant chemotherapy, radiation therapy, and adjuvant aromatase inhibitors. So she completed 5 years of adjuvant aromatase inhibitors, and 1 year after, she had a right hip pain, and the bone scan revealed the bone metastasis. At the same time, we completed the staging, and we discovered many liver mets, bone mets, and so we performed the liver biopsy. And the biopsy showed the R-positive, PR-negative, HER2-negative metastasis from breast cancer. We decided also to perform an NGS since we were managing at that time some clinical studies, but there was no ESR1 mutation, no PI3 kinase mutation, no AKT or PTEN alteration, and the patient was wild type for germinal BRCA1 and BRCA2. Liver function test was normal. She was actually a little bit depressed. So this is the clinical case, and now what we have to do is to decide which will be the first-line treatment. So 5 years of AI, the patient relapsed 1 year after the end, so this is an endocrine-sensitive disease, which is the optimal treatment. So if we check the clinical studies with CDK4/6 inhibitors, we have studies for endocrine-sensitive disease, and all of them have been designed including an aromatase inhibitor. So because if you relapse 1 year after the end of CDK4/6 inhibitors of adjuvant AI, you can re-challenge again with AI. And then we have studies for endocrine-resistant disease, in which fulvestrant was the partner. And you will see here that across the clinical studies in the first-line setting, all of them demonstrated on the primary endpoint, that was median progression-free survival, a median PFS benefit. Some of them demonstrated also an overall survival benefit. If we check the data, the MONALEESA-2, first-line aromatase inhibitor plus ribo, demonstrated also an overall survival benefit. In the PALOMA-2, there was a benefit in median progression-free survival, but no benefit in overall survival. The trial was negative for the secondary endpoint, overall survival. And finally, we have the MONARCH-3, a statistically significant benefit in terms of median progression-free survival, and also, even if not statistically significant, clinically meaningful benefit in terms of overall survival. So there was a longer overall survival benefit when combining abemaciclib plus non-steroidal aromatase inhibitors. In the MONARCH-3, of course, also testing the activity in patients with visceral mets, specifically like our patient, there was a huge benefit in terms of overall survival. Just checking the subgroup analysis in the MONARCH-3, you will see the benefit was independent of site of metastatic disease, bone only versus not bone only, prior endocrine therapy, disease setting, de novo metastatic versus relapsing, age, and progesterone receptor status. So if we compare the MONARCH-3 to the MONALEESA-2, you will see finally that in terms of median follow-up, we have a very similar follow-up. Randomization was 2:1 in the MONARCH-3, was 1:1 in the MONALEESA-2. And the number of patients finally can be different in terms of patients that have been randomized across the two arms. But the median overall survival numerically is very similar if you check the data on the MONALEESA-2 and the data on the MONARCH-3. Let's go now on the safety profile. You know perfectly that not all CDK4/6 inhibitors are created equal. So palbociclib has much more neutropenia, quite infrequent diarrhea, also less frequent liver toxicity. The schedule is 3 weeks on, 1 week off, with a dose of 125 milligram daily. Then we have ribo, in which the most common toxicity is neutropenia. There can be some diarrhea. Also, ALT and AST alteration may occur. Sometimes it's a little bit difficult also to manage, even if you do a dose reduction. And the dose in the metastatic setting is 600 milligram daily. And finally, we have abema, that is a continuous schedule. Neutropenia is less frequent. We have diarrhea as the most common toxicity, very rare liver toxicity, and thromboembolic events eventually described also in the clinical studies. So this was a patient endocrine sensitive, but in the first line, you know perfectly we have another option, mainly reserved to endocrine resistant disease. And Dr. Javeri presented this beautiful data during San Antonio last year, and then we know that there is an update on overall survival that will be presented and published soon. So the INAVO 120 included a combination of inavolisib, that is a PI3 kinase inhibitor, plus fulvestrant, plus palbociclib in the first-line setting. And as you can see here, there is a huge dramatic benefit in terms of median progression-free survival, increasing median PFS from 7 months to 15 months. So which is the treatment algorithm in ESMO? In the first-line setting for patients with HR-positive, HER2-negative disease, the standard of care is endocrine therapy plus CDK4/6 inhibitors. The endocrine partner can be aromatase inhibitor if you have an endocrine-sensitive disease, fulvestrant if you have an endocrine-resistant disease. Chemotherapy should be used only in patients with imminent organ failure or visceral crisis. And if you progress to endocrine therapy plus CDK4/6 inhibitors, we have a biomarker-driven approach that will be better explained by Dr. Javeri because she will address the second-line therapy. So the biomarker-driven approach, of course, should consider testing for ESR1, for PI3 kinase, for AKT, for PTEN, and eventually for germinal BRCA mutation. So just to do some consideration for individualized selection in the first-line setting, so how we should select between abema, palbo, or ribociclib. Selection should be based, of course, on the level of evidence of data. If you check in the ESMO guidelines, we have magnitude of clinical benefit scale, and some drugs have a lower value, some others a higher value, because if you have an overall survival benefit, of course, this can drive your selection. But I believe you should also consider patient age and performance status, comorbidities, eventually concurrent medication, presence or not of endocrine sensitivity or endocrine resistance, the drug dosing, continuous versus intermittent, and potential drug-drug interaction. These are all the factors that we may consider when we have to select the first-line therapy, sometimes also the menopausal status, I would like to say. So let's go back now to our clinical case. I remember to you she was a postmenopausal woman, relapsing 1 year after the end of adjuvant endocrine therapy, liver mets with a biopsy confirming HR-positive, HER2 negative disease. So the question for you, which will be your preferred option in this patient with liver and bone mets, metastatic breast cancer, endocrine sensitive disease?
Thank you so much, Dr. Corigliano. I thought maybe we could take a moment or two to maybe address a couple of questions on part one as well. But just talking about the first line, and we heard from Dr. Corigliano, why would we think about CDK4/6 inhibitors for endocrine sensitive tumors? We obviously have 3 available. We've based the choice certainly on the level of evidence where we've seen all the data for all of them. For progression-free survival, which was the primary endpoint, we've seen overall survival data sets, which is why folks have started using now ribociclib and abemaciclib. He walked us through the INAVO 120 patient population. What do you do in your practice in terms of testing for biomarkers? Do you do that in the first line? And if you do you use tissue? Do you use plasma? And when would you consider using that information in the first-line setting?
Okay, this is an excellent question. I believe it will be available soon in AVO in our country. There is an expanded access program already available. So in our country, we cannot delay the use of any treatment. So if you have an endocrine-resistant disease and you would like to consider a frontline treatment, we have to test when the patient will relapse in the first line. And we test for PI3 kinase, eventually both on the liquid biopsy or on the tissue biopsy, because sometimes you can, of course, identify PI3 kinase mutation in liquid biopsy from 30 to 35% of the patients. But if you don't have evidence in the liquid biopsy, I will retest eventually on the tissue in order to be sure that you don't have the mutation. We have to do this because or you will give INAVO or the first line, or you cannot give later. Right. So I believe the INAVO trial will anticipate testing for NGS in metastatic breast cancer,
Absolutely.
At least in Europe. At least in Europe.
Yeah. And so it's available now in the United States. It's FDA approved. So certainly our practice patterns have to shift a little bit because, as we said, we'll talk a little bit more about biomarker testing and how important it is once the tumor has had progression with a CDK4/6 inhibitor in the second-line setting, because we certainly have so many therapies available in the second line. But because of this data set from INAVO 120, certainly that mindset about thinking about these mutations for the relevant patient population, which is patients who would have been eligible for fulvestrant as the endocrine partner, which is patients progressing on their adjuvant aromatase inhibitor or within 12 months of their adjuvant endocrine therapy, where you would have otherwise offered them fulvestrant, that's where you want to test for a PIK3CA alteration, picked up in up to 40% of the patients, and you would want to offer this therapy given the doubling of PFS that you saw from 7 months to 15 months. And the press release said the OS benefit was also clinically significant and statistically significant. We hope to hear details of that at the upcoming meeting. So certainly to keep that in mind. PIK3 mutations can be tested in tissue. They are truncal alterations. Primary or metastatic is fine. In the metastatic setting, we already have a biopsy to confirm metastatic disease, so it becomes easier. But certainly, ctDNA has the advantage of a quick turnaround, and you could still get that result as well. So something to keep in mind. Let's now talk about second-line therapies, and we'll have more opportunities to talk about other questions that we might have about how do we utilize these test results. So I'll focus on making the most of expanding the therapeutic arsenal for pre-treated hormone receptor-positive breast cancer. And we'll certainly focus more on the development of oral SERDs and other novel endocrine agents in this space. So let's start with a case here. We have a 58-year-old postmenopausal woman with ER-positive, HER2-negative metastatic breast cancer. She received her first-line CDK4/6 inhibitor. In this case, it was palbociclib with an aromatase inhibitor. 18 months later, on this first-line therapy, developed asymptomatic progression both in the bone and in the liver. A circulating tumor DNA assay testing was done. This revealed ESR1 mutation, no alterations in the PIK3CA, AKT, or PTEN pathway, no germline BRCA1 or 2 mutations. Keep this case in mind. We'll come back to it and discuss it after we review the supporting evidence. So let's walk through some data and see where are we with the question that we were talking about that came in online as well, thinking about CDK4/6 inhibitors beyond progression. So what do we have in terms of what is available for evidence in terms of this question? We have 3 trials that are summarized on this table. We have the MAINTAIN trial that evaluated fulvestrant with ribociclib after majority of the patients had had palbociclib, 84%. This was a randomized phase 2 trial of 120 patients. And then we have PACE and Palmyra, where we had patients who had palbociclib in the first line with an AI, switched over after progression to fulvestrant, but continued the palbociclib. So 2 separate things happening, right? We have a scenario where patients had AI, palbociclib, and at time of progression switched both the endocrine partner and the CDK4/6. And in PACE and Palmyra, they only switched the endocrine partner, but continued the same CDK4/6 inhibitor. Guess what? With MAINTAIN, when we switched both, we did see a statistically significant improvement from 2.8 to 5.3. In PACE and Palmyra, we did not see a difference by switching just the endocrine backbone and continuing the same CDK4/6 inhibitor. But in this case, this was with ribociclib. So right now, at least from these data set, it felt like when you're switching both, you might see some benefit. PostMonarch was a phase 3 trial, again, trying to address the same question. In this case, we had patients who had either progression on AI CDK4/6 in the metastatic setting or could have had recurrence of endocrine therapy, including a CDK4/6 inhibitor in the adjuvant setting, no other prior therapy for metastatic setting. 368 patients randomized to fulvestrant abema compared to fulvestrant placebo, again, looking at a primary endpoint of investigator-assessed PFS. Here are the Kaplan-Meier curves for that. The improvement in the control arm from 5.3 to 6 months with abemaciclib fulvestrant. Hazard ratio is 0.73. This was statistically significant. So the improvement is rather modest. This was, however, statistically significant. And you do kind of see that dip at the 50% time point in this Kaplan-Meier curves, perhaps suggesting why the benefit, the delta of benefit looks that modest. But this was at least a phase 3 trial, again, confirming where majority of the patients did receive palbociclib or ribociclib and then switched over to abemaciclib, and they had AI in the first-line setting and switched over to fulvestrant. So when you're switching both, it did seem like, again, that strategy might work. What about everolimus and fulvestrant? So we know that Bolero-2 had given us approval for everolimus, but that was in CDK4/6 naive patients. We had some real-world data set, and then this is a phase 2 trial that got published last year. It's a French experience, a small study where they looked at fulvestrant and everolimus after CDK4/6 inhibitor progression in the whole population shown on the top, and in patients with previous palbociclib treatment duration in the bottom. On the left, you see the progression-free survival, where the median in this straight phase 2 is 6.8 months, median overall survival on your right, which is 38 months. So there is some prospective evidence in a phase 2 setting post-CDK, where we think that fulvestrant Evro can give you something around 6.5 months. Again, small study and not randomized. Let's move on to oral SERDs. Why do we need oral SERDs? We certainly had tamoxifen, we have aromatase inhibitors, we have fulvestrant, but we know that while these work, there are challenges both related to toxicity, both related to their pharmacological limitations. With aromatase inhibitors, not only do we have toxicity, which also translates into non-compliance, non-adherence in clinic in the early stage as well, but we also see that under the selective pressure of aromatase inhibitors in the metastatic setting, there is development of ESR1 mutations. Tamoxifen works, however, can have weaker ER expression. So we know that it works in a tissue-selective fashion as an agonist and antagonist. It has weak ER expression. Fulvestrant works despite prior endocrine therapy, but again, it has to be given intramuscularly, lacks oral bioavailability. Post-CDK4/6 inhibitor, the activity is rather modest. And we've seen that in certain ESR1 mutations, such as Y537S, for example, the activity of fulvestrant is rather limited. And of course, patients would love to have an option that is oral and not just have intramuscular injections monthly. And this is why we're thinking about what can we do more. And again, these ESR1 mutations is what we were talking about that develops under the selective pressure of aromatase inhibitors. These are rare in primary tumors, again, because it's happening under the selective pressure in the metastatic setting. But in the metastatic setting, they can be as prevalent as up to 40 to 50% in the second or third line metastatic setting. So a significant number of patients' tumors can develop this mutation, which is ligand independent, but ER dependent. So really, it's almost like a biomarker that this tumor still relies on the ER pathway. It's just that it's ligand independent. It does not require estradiol, and it is not competing with estradiol anymore, but it is ER dependent. Now, because it develops under the selective pressure of aromatase inhibitors, and it's acquired, unlike PIK3CA, which are truncal alterations that can be detected even in the primary tumor, it makes more sense for ESR1 mutations to be detected in liquid assays, because liquid will give you a good readout from all tumors in the body and not necessarily just from the tissue biopsy in one site, right? It could be taken from the liver, but it would miss an ESR1 mutation, for example, in the bone. And that is what this slide is showing you, that you can identify more ESR1 mutations than contemporary biopsies because these are subclonal acquired mutations. When you think about prevalence in the tissue, it's about 20%. When you think about prevalence of these alterations in ctDNA, they could be as high as 40 to 50%. So something really important for us to remember when we think about biomarker testing for ESR1 mutations. And this is telling you why, because of these ESR1 mutations, we are working so hard to try and figure out what other novel endocrine therapies could overcome all these issues with toxicity, oral bioavailability of fulvestrant, the PK issues, the modest clinical activity we've seen, and importantly, overcome the ESR1 mutations. And all these oral SERDs, novel SERMs, we have PROTACs, we have CERANs, we have SERCAs. Idea is really, how can we downregulate the estrogen receptor with any of these agents or more than one of these agents that have optimal therapeutic index, a good efficacy profile, a good toxicity profile, and that can overcome these challenges, including for ESR1 alterations. And multiple oral SERDs entered clinic. This table is just summarizing the trial population. For 4 of these trials, Emerald studied LSS strand that led to the approval of LSS strand in clinic for ESR1 mutant tumors. This was the only phase 3 study in this table that is shown. For men or postmenopausal women, 48% had ESR1 mutations at baseline here. They did allow prior fulvestrant, 30% had prior fulvestrant, and we know that this is a positive readout of a trial that led to its approval. SERENA-2 studied camizestrant, it's a phase 2 study, did not allow prior fulvestrant, so different, did not only focus on prior CDK4/6 inhibitor, unlike EMERALD, which was 100% prior CDK. This was approximately 51% prior CDK, but a positive signal. And unlike EMERALD and SERENA-2, AMEERA-3 and ACCELERA with amcenestrant and giredestrant respectively were negative trials. But again, these were phase 2 studies. They had different patient populations. This table is not trying to do a cross-trial comparison. It's just trying to provide a comprehensive data set that we have available for monotherapy oral SERDs, some with positive readout, some with negative. But despite the negative overall readout with different trial patient populations, different prior therapies, and ESR1 mutations, what we saw as a common signal across these trials, which is what is being captured in these Kaplan-Meier curves, on your right is a positive study with EMERALD, where we did see a statistically significant improvement or near doubling of PFS from 2 months in the control arm to 4 months hazard ratio of 0.55 with EMERALD and elacestrant. Even though AMEERA and ACCELERA were negative, the signal for ESR1 compared to the intent to treat population was consistent, meaning the benefit was better with monotherapy oral SERD, even in this negative readouts in the ESR1 mutant population, kind of suggesting that when you have this endocrine sensitive tumor, right, the surrogate for endocrine dependency, which is ESR1 mutation, you might see benefit for a rather optimal endocrine therapy. Now the question is monotherapy going to be enough for all? As you can see in these Kaplan-Meier curves, 40% across the board will still have early progression on monotherapy, and 60% still have less than 6 months of benefit in clinic, indicating that maybe even though we have patients where monotherapy can be justified, there is a good proportion that might benefit with combinations with these oral SERDs. And this, in that context, let's talk about what readouts do we have for some combination agents as well. This is the phase 3 EMBER-3 study. We presented the results at San Antonio and simultaneously published that as well. This is for patients who have had recurrence on or within 12 months of an adjuvant aromatase inhibitor with or without CDK4/6, or prior therapy with, again, AI or prior CDK4/6 in the metastatic setting. 874 patients randomized to one of the 3 arms, oral SERD alone, physician choice endocrine therapy, or the combination of imlunestrant plus abemaciclib, which was a 3rd arm that was added as a study amendment early in study accrual. 3 primary endpoints here. 1, looking at monotherapy comparisons in ESR1 mutants. 2nd, looking at monotherapy comparisons in all patients. And if either of the 2 in ESR1 or intent to treat would be positive, then the 3rd endpoint would be to look at the doublet of imlunestrant plus abema versus imlunestrant for median investigator-assessed PFS. So in terms of patient demographics, approximately 37% in the baseline tumors had ESR1. Approximately 38% had alterations in either PI3K, AKT, or PTEN. 30% of the patients had progressed on or within 12 months of adjuvant endocrine therapy, and 2/3 had progressed on or within 12 on their first-line metastatic therapy. 60% had prior CDK4/6 in the first line before they enrolled, or prior CDK4/6 before they got the treatment on EMBER-3, majority being palbociclib and ribociclib. And baseline characteristics were otherwise well-balanced. For the first primary endpoint, looking at imlunestrant versus physician choice endocrine therapy in ESR1 mutant tumors, there was an improvement in PFS from 3.8 to 5.5 months. Hazard ratio is 0.62, which was statistically significant. Unlike that, in the intent to treat population, we did not achieve statistically significant results. Improvement from 5.5 to 5.6, hazard ratio is 0.87. Notably, majority of these groups without ESR1 mutation, so remember 37% had ESR1, majority that did not have it, showed no difference in PFS. The hazard ratio there was 1. But because in the ESR1 mutant tumors it was statistically significant, this third primary endpoint was looked at, which was imlunestrant plus abema compared to imlunestrant alone. And here you see the improvement with the combination of 9.4 months PFS. Hazard ratio is 0.57. This is statistically significant. Now, monotherapy showed benefit only in ESR1. What about the combination? When we looked at combination with ESR1 mutations or without ESR1 mutations, the benefit was consistent. On your left, median PFS improved from 5.5 to 11.1. On your right, in without ESR1 mutations, the benefit improved from 5.5 to 9.1. So consistent hazard ratios with or without ESR1 mutations. Similarly, we looked at important subgroups. 65% of the patients had CDK4/6 before they got the doublet. And in that group also, median PFS improved from 3.7 to 9.1 months, hazard ratio of 0.51. In patients who have PIK3CA alterations, again, improvement from 3.8 to 7.6 with imlunestrant abema, hazard ratio of 0.6. Now, 65% we said had prior CDK4/6 with the doublet. This is a forest plot for those patients. It did not matter whether you had palbociclib or ribociclib. That was 2/3 and 1/3 of the patients. The hazard ratios you can see is 0.43 and 0.57. The abemaciclib group was really, really small. There is some benefit seen, but the confidence intervals are very, very wide because very few patients got abemaciclib. But as again pointed out, benefit was seen regardless of ESR1, PI3K, or both ESR1 and PI3K tumors as well. What about safety? Imlunestrant was well tolerated. The most common toxicity was fatigue, diarrhea, or nausea. But this was no more than 10% higher than the standard endocrine therapy arm. In fact, if you look at the grade 3 or higher toxicities, it was 17% in the imlunestrant arm, 21% in the physician choice endocrine therapy arm. Dose discontinuation rates were low at 4%. And as expected, 9% of our patients reported adverse reactions related to injections with fulvestrant, but 72% in a patient survey reported injection site swelling or discomfort or redness, kind of suggesting that certainly the patients would obviously prefer having an option as a pill compared to an intramuscular injection. What about the combination? Certainly, you would expect more diarrhea, given that we know abemaciclib can cause diarrhea. But thankfully, even this higher diarrhea was grade 1, and there was no new safety signal, nothing worse than what we have seen with fulvestrant abema in the past as well. If anything, it was better in this data set with imlunestrant, with discontinuation rates for this combination, again, being very low at 6%, which was very reassuring. So really, we have that data set for imlunestrant monotherapy like elacestrant. Now we have data for this combination. And as I was saying, there are multiple other endocrine agents. Lasofoxifene is a SERM. We have selective estrogen receptor covalent antagonists or SERCAs. We have proteolysis targeting chimera such as vepdegestrant and complete estrogen receptor antagonists like palazestrant. We have compelling data from phase 1 suggesting they work post-fulvestrant. They work better in ESR1 mutant tumors compared to the intent to treat patient population. Multiple in phase 3. In fact, from the phase 3 trial, the VERITAC-2 trial, again looking at vepdegestrant, the PROTAC against physician choice endocrine therapy, there was a positive press release that came out. Trial met its primary endpoint in ESR1 mutant population for monotherapy comparison, not in the intent to treat population. A similar signal that we're seeing across the board with these agents. All of these agents are also being in phase 3 trials that are currently ongoing. So really, except for the SERCAs, but really, we're waiting to see a similar activity with monotherapy and hopefully more data sets with combinations to have this available for our patients in clinic. So let's put this into context for our patients. This was a wonderful slide that Dr. Burstein actually showed at San Antonio when he did the discussion, when the EMBER-3 study was presented. And this is not, again, to make any cross-trial comparisons, but it kind of gives you a flavor of what do we have in the second-line metastatic setting with monotherapy, EMERALD, SERENA-2, with lasofoxifene in the ELAINE-1 trial. We have capivasertib and fulvestrant for PI3K/AKT mutant tumors. And you see the median PFSs for all these available data sets, may it be MAINTAIN, may it be CAPItello, and now with EMBER-3 as well. And you see that the EMBER-3 PFS is kind of towering highest in some ways with 9.1 month in the post-CDK4/6 group as PFS, which seems to be a nice signal. We have seen a press release from SERENA-6, which is going to be very interesting to see when it gets presented, hopefully at ASCO. We're going to see an approach of adapting therapy. So that is a first-line study. We monitor ESR1 mutations on first line. If you see ESR1 but no radiological progression, patients would switch over to camizestrant CDK4/6, and the control arm will continue their current AI CDK4/6, and that was a positive signal as a press release. So we're looking forward to that data as well to see what would be a good approach. I'll leave you with this treatment algorithm. Dr. Curigliano covered the first line for endocrine sensitive for the CDK. For endocrine resistant, we can do triplet with Inavo if it is resistant, but usually we'll think about biomarker-based approach. We have alpelisib for PIK3 mutants. We have capivasertib for PI3K/AKT/PTEN alterations. We can consider elacestrant for, or offer elacestrant for ESR1 mutant tumors. If imlunestrant gets approved, that might be an available option as monotherapy. We saw the data for imlunestrant abema that worked regardless of ESR1 or PIK3CA. We certainly have fulvestrant everolimus, which we can use regardless of PIK3CA. So we have multiple of these options that could be based on the biomarker and some even without the biomarker. And then eventually for endocrine refractory disease, we do chemotherapy and antibody drug conjugates. Patient perspective, I think, is going to be very, very important. Patient preferences are very, very important for all therapies. And accumulating evidence really suggests that oncology patients do prefer oral therapies for various reasons, including convenience, for not having the burden of coming to the infusion center to get their infusions, and just avoiding extra inconveniences and pain from other systemic options, which also highlights the importance of why adherence is very, very important as well, because you can only derive that benefit with oral therapies if you have adherence to that oral therapies. And there are multiple factors that influence that, which could be patient-related factors, which could be healthcare system-related factors, social or economic factors, therapy-related factors, or disease-related factors, and a variety of measures to improve adherence, which is really, really tied into patient outcomes, including therapy-related interventions of how we can simplify and make it easier for our patients, educate them, have them communicate that back to us, and patient-related interventions as well that are really, really important for adherence. So now let's go back to our case. We have this 58-year-old, first-line palbo aromatase inhibitors for 18 months, now asymptomatic bone and liver metastases, ctDNA revealing ESR1 mutations, no PIK3CA, AKT/PTEN, no germline BRCA. What are the considerations that we make? Dr. Curigliano,
we have time for a couple of questions. So let's start with the first one that is a little bit provocative. So the study design of EMBER-3.
Yes.
You compared A versus B and then A versus C.
That's right.
But A was not the standard of care.
Correct.
So how you believe regulators will take a decision in order to approve eventually the combination of imlunestrant plus abemaciclib, since you clearly showed that there is a benefit. So, and also in the poll, the majority of the audience would go for that combination. Right. A comment on this?
Yeah, no, I think it's a very good scientific question and a very tough regulatory question, because I think regulatory decisions are definitely bound with regulations that they have to follow. I think when the study was designed, it made sense to obviously first show monotherapy activity, which is why the primary endpoint was looking at monotherapy comparisons against physician choice endocrine therapy. And then, as the field was evolving and as our understanding was evolving around the science, that not all patients can just benefit with monotherapy endocrine therapy, we do need combinations, it made sense to think about a combination arm and compare it to what's superior in the study. And so certainly we were expecting imlunestrant to be superior, so the combination to monotherapy made sense. At that time, we did not have data sets such as the post-monarch data set for fulvestrant abema. We didn't have approval for combinations like that to be able to study that as a control arm. So the control arm here obviously is going to go after what was active here. We can't answer all questions in one study. This does give you a flavor of, do combinations make sense? Do combinations have to rely on ESR1 mutation? Can we go beyond? Because that is the clinical unmet need for our patients in clinic. So for clinic, I love the idea that this combination addresses that concern. Unfortunately, I'm not sure I can answer the regulatory decision about this, and we'll see what they do. The overall survival readouts are rather immature, with 15% maturity for the doublet. We'll see with more follow-up what happens there.
There is another question I believe is very interesting. Now we have several oral cert. Elacestrant approved, the imlunestrant will be approved, maybe camizestrant also. So how much the results of all the clinical studies can be impacted by the number of patients who received previous CDK4/6 inhibitors?
Yeah, so I think what we have seen across all these trials is that despite prior CDK4/6 inhibitor, you are seeing activity with these oral SERDs as monotherapy. And similar to what we've seen, we have 3 CDK4/6 inhibitors. We now have 4 agents targeting the PI3K, AKT, mTOR pathway, right? We are going to see a lot of these novel endocrine therapies having positive readouts and get approved. We'll see vepdegestrant with a positive press release. We already have elacestrant. Imlunestrant is positive and will get approved. Camizestrant looks like it's going to get approved. So we will have these choices, and it seems like monotherapy can work for some patients, and we will offer them for some patients, and we have choices. And they all kind of look, they're well tolerated with some differences in their toxicity profile, so we will all have our preferences. Patients will have their preferences. We'll discuss that with our patients and make a shared decision-making process. The question is then, with the combination readouts, should we do that in the first line? Should we do the combination in the second line? Should we do a Serena-6 like adaptive approach? We still have to get all these data sets and review them together to see what the first PFS looks like, what do patients do after progression on these doublets in the second line, might we see any overall survival benefit, which is going to be very hard to look at, and then decide if one approach is the only right approach, or we might alter our decisions based on these readouts.
We have a final question. We have many, but I have to select. This is from Asia, so that's why I am asking. So with all this combination under evaluation, is there a role for endocrine monotherapy in the second line? And if yes, for which patients? Yes.
It's a fantastic question. So why monotherapy? I think there is a role for monotherapy. I think what we have learned so far from the EMERALD subgroup analyses and what we do in clinic for years, if you have somebody who's responding really, really well and has what we think endocrine-sensitive tumor, even with the CDK4/6 inhibitors, we'll have patients who do really, really well for a very long time. The subgroup analyses showed that patients are staying on their first-line therapy for 12 months or more and have an ESR1 mutation, which we said is a surrogate of endocrine dependency. The tumor is progressing using the ER pathway. Monotherapy would be very appropriate because it's very well tolerated, it's one drug, and we can offer that. Unfortunately, it's not that simple. The tumor biology is complex. Not all patients will have that. So we do think that combinations still have a role where we think there are other pathways playing. There is more significant tumor burden. Patients probably don't have their first-line durable benefit with CDK, and it's progressing faster where we think about combinations. So I think there is a group of patients which will have monotherapy, which is appropriate to choose based on the durability and ESR1, and for others, we will have doublets.
So thank you very much for attending. Have a nice day.
Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education, and by the European Board for Accreditation of Continuing Education for Health Professionals. This activity is developed with our educational partner, breastcancer.org. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/VPA860.